Thanks so much, Andrew. And as always, thanks to the AOC PM&R for having me. Let me do a quick share screen. Make sure it comes up. Okay, good. All right, so yeah, I'm trying to squeeze two case studies in one slightly less than an hour presentation, which because I'm a talker and it might end up being a little bit challenging for me, but I will do the best I can. So with that said, please just understand that with a lot of these slides, I'm just going to be flying through them because as I created the presentation, I'm fully aware of which slides are a little bit more important than other slides. And so I want to just make sure that I don't spend too much time on the slides that aren't quite as important. So we're going to start with case study number one, which is my shoulder self-rehab. And I might as well just get to this first slide and you'll see what I'm talking about as I go through this. So I ruptured my left side, left arm, long head bicep tendon proximal at the shoulder. And I have a full thickness tear of my supraspinatus. More on that in a second because I have my MRI report on a slide. And then a partial tear at my superior labrum. And so here's the quick history of what happened. And there's probably some stuff prior to this as well. But basically in October 2020, not that long ago, I was creating a educational video on what it means to take yourself to muscle failure, the difference between muscle failure and what's called repetition maximum, and then the difference between those and terminating sets, resistance training sets, submax, where you knew you had some repetitions left in reserve, and trying to show a difference between a working set and a warm-up set when you're terminating set submax. And I personally, I turned 56 in a month from today, actually. And I'm done taking myself to muscle failure. I used to when I was in my 20s and 30s. Those days are over with. So the point is that I hadn't taken myself to muscle failure in probably years. And now, because I'm creating a video in a 48-hour period, I took myself to muscle failure on probably somewhere around 12 to 15 sets of various upper body exercises. And about a day or two after I completed this, my left shoulder was just screaming at me. But the truth is, it was very intermittent. So basically what I was feeling was a lot of achiness and throbbing, but it wasn't constant. It was just during the day, it wasn't really at night, certain times of the day when I was doing certain things like walking to work, carrying a shoulder bag over my shoulder, things like that. But there was also some numbness and tingling that was also very intermittent, just enough to be annoying, but none of this really felt enough that I needed to see somebody about it. Maybe some of it was my own stubbornness, but it was just really intermittent. So it was more annoying than anything, but it was definitely throbby, achy, and a little bit of numbness and tingling going down to my elbow and on occasion down into my hand. This lasted for about 4 to 6 weeks. And then somewhere around the early December of 2020, everything just got back to normal. I didn't feel any pain or any of the symptoms anymore. And I also was able, between December and mid-March of, not that long ago, 4 months ago or whatever, I was able to progress back to in strength to pre-pandemic levels, which for me, just to give you an example, I'm doing this just to give you a sense of what my capacity is, which will make a lot more sense because I have a video in one of the future slides so you can understand why I chose the start points I did after this injury. But basically, like, I was pressing 100-pound dumbbells, chest press for like 6 to 8 repetition, 105-pound dumbbells for like 3, 4, maybe 5 repetitions on a good day, rowing 200 pounds, 220, etc. So in any case, then in mid-March, I made the mistake of doing bench press, which when it comes to chest press, I'm almost always dumbbell pressing. I avoid barbell chest press for the most part, but for some reason I decided not only to do barbell chest press, but to go heavy. I did a 2-rep max, And I felt fine during the session. No pain or anything, but about a day or two later, here comes that throbbing and aching back into the picture. There was no numbness or tingling this time. It was also intermittent, just like it was the first time around, but that annoying throbby achy feeling in my left shoulder. And then, so what I decided to do was I decided to take 3 weeks off of upper body training, and just, since I had just had this happen months before, it was fresh in my mind, and I thought to myself, you know what, it's not going to kill me to take 3 weeks off. I'm not going to do anything from an upper body standpoint. I'm just going to let it go. And about 3 weeks later, on April the 3rd, you're getting ready to see here in an upcoming slide what happened. So I'm not going to say it in this slide, but I had a partial tear of my biceps tendon. I didn't know it was a partial tear at the time because I didn't really know what a full rupture meant, but I did know that I did something that I messed it up pretty bad. And then 5 days later, I was in the shower and reaching up towards my head to wash it or whatever. And that's when I knew that the rupture happened, and more on that in a second. So here's my MRI report. Let's go down to the second one first. Long head of the biceps tendon, complete rupture, and it retracted 6.5 centimeters. So now, from what I understand, it's just kind of finding a spot on my humerus to lie down, and scar tissue will attach it there. Going up to my rotator cuff, a full thickness, partial width tear of the anterior fibers, measuring 1.3 centimeters, which is equivalent to a large but not a massive tear. But it also includes retraction to the middle third of the humeral head. And then at my labrum, I have a partial tear at the superior labrum where the biceps tendon attaches. So on that note, so just know that in future presentations that I give, I will definitely spend some more time on functional anatomy than I'm going to in this presentation, only because in this one, I'm trying to squeeze 2 case studies into one. So this is going to be pretty quick, but this is from a website, 3D functional, or actually just kinesiology and anatomy and musculoskeletal website called muscleandmotion.com, which I really highly recommend. I'm a big fan of it, and I have a subscription to it. So with the supraspinatus, which is what I have, a 1.3 centimeter tear. As you can see, the origin is the supraspinous fossa, and the insertion is at the superior surface of the greater tuberosity right here. And then from a functional anatomy standpoint, yes, it assists in shoulder abduction, but it is primarily, it's really your deltoids that's doing that, which I'm totally experiencing now. That this tear just isn't really affecting my strength at all. Let me pause this for a second. This is the infraspinatus on the posterior side of the scapula. The origin is the infraspinous fossa, and the insertion is the greater tubercle, as you can see here, and it is an external rotator. So there's the infraspinatus. And then the next one, which I'm going to do a pause here, is the teres minor, very small. Also an external rotator. Lateral border of the scapula is where it originates, and it inserts at the greater tubercle of the humerus on the back side, which is why it is or posterior side, which is why it is an external rotator. And obviously its primary function is really more as a stabilizer than it is as an external rotator. And then let me pause this again. Here is the subscap. On the anterior side is an internal rotator. It originates at the subscapular fossa and inserts at the lesser tuberosity on the anterior side of the humerus. Internal rotator. Your pecs also serve as a primary internal rotator as well. And then here's your biceps, and here is the short head of the biceps, which I am learning now because of what I'm experiencing, and also from what I've learned from the the orthopedic surgeons and the physiatrists that I spoke to immediately after this happened, it's actually pretty interesting now that I'm going through this, that it almost seems to me you don't really need the long head of your biceps. It's primary a shoulder stabilizer, but um, I've learned that 95% of your power and your strength comes from the short head, and I'm absolutely experiencing that. So really the first orthopedic surgeon I spoke to, once he learned through the MRI that I have a supraspinatus tear and it's pretty large and it includes retraction, he suggested surgery and basically said that from a long head of the bicep standpoint, it's like 95% aesthetic. It's really not going to negatively affect my function if I don't have it reattached. Um, uh, but he suggested that because there's retraction in my supraspinatus, that he goes and fixes that, and while he's fixing it, he also staples the long head of my biceps somewhere up further up on my humerus, because you just can't reattach it at its original origin. But as you can tell, I decided not to get surgery. More on that in a second. Let me actually just go to the next slide. So before I go into this etiology and how it relates to me, after after the rupture occurred, and once again I was in the shower, and so basically what happened was, let me actually start with this etiology because this will make more sense. So here it says that the tendon rupture usually results from a sudden contraction of the biceps associated with resisted elbow flexion and supination of the forearm. This was not really the case with me. What happened with me was I was on a leg press and I was just gripping the side like you do to stabilize yourself. And I was going kind of heavy. It was like a 6 reps. So it wasn't like a 1, 2, 3, or 4 rep max or anything like that. It was 6 repetitions. And first set, I felt nothing. Second set, maybe like the third rep into the set, I felt some popping. No pain associated with it whatsoever. Just felt some popping. And I've dislocated my right shoulder and have subluxated a few times. So I had that to compare it with. And I knew something was going wrong with my shoulder, but because there was no pain at all, and because I was in this neutral position and there was no movement going on in my shoulder, I couldn't tell how bad it was. So I continued with my set. Next repetition, nothing happened. And then the next repetition which was like my 5th rep. I felt some more popping, and it just felt like I needed to, almost like cracking your knuckles type of thing. I just felt like something was wrong. So I terminated the set. I stood up. I immediately, as you know, normal range of motion and flexion is 180 degrees. Same thing with abduction. I only had like maybe 15, 20 degrees of flexion.
Yes.
Okay, I'll just start from this slide and I'll go as fast as I can. I
Good.
apologize about that, everybody. This literally never happens. I don't understand why it's happening, but I'm on my phone hotspot now and hopefully it'll work. So in any case, I don't remember exactly where I left off, but let me actually go to, so it happened while I was on a leg press. My arm was almost in a neutral position. Heard popping sounds, no pain, barely had any range of motion once I stood up, but still just wasn't in that much pain. But I knew intuitively, obviously, I needed to stop my workout. Over the course of the next 4 or 5 days, my range of motion started to, first of all, I had no swelling, no bruising, continued to have no pain. My range of motion increased from like 15 to 20 degrees to like maybe 30 or 40 degrees over the course of the next 4 or 5 days. Then I'm in the shower, washing my head, feel a couple more pops, no pain associated with it, but knew at that point that something major had just happened. Get out of the shower, look in the mirror, see the Popeye. I don't know if you can see or not, but yeah, not sure if you can really tell, but definitely have a divot here now in the Popeye. And I knew right then I completely ruptured it. Next day, I see Amir Mahajer in his office, and also within that 24 hours, my range of motion came back because now my biceps is no longer attached. So there is nothing to inhibit my range of motion. So within 24 hours, I had full range of motion, or at least pre-injury range of motion. I have kind of tight shoulders, but I had 180 degrees of flexion, abduction, probably about 80 degrees of external rotation, et cetera, et cetera. And so it was just a really strange injury. In any case, on April the 12th, actually, let me go back. On April the 12th, I got my MRI, and that's when. Can you hear me okay? Because I know I would just went out.
Yeah, you April 12th is all I heard.
Okay. Fortunately, my screen warns me that this is happening. So on April the 12th is when I got my MRI. That's when I knew, obviously, significantly worse injury with the supraspinatus tear. Spoke with 3 orthopedic surgeons and several physiatrists. Only one of the orthopedic surgeons recommended surgery. The other 2 said, nope, your MRI shows that your other 3 rotator cuff tendons are intact and they look strong. And obviously your deltoid is going to compensate. And they also told me that this isn't a situation where it's emergency surgery. They said this is something that, since you are asymptomatic, you don't really have to worry about right now if you don't want to, and that you can go into your rehab. And then if a month or 2 down the road you're starting to become symptomatic and decide you want surgery, you can go that route, which is what I decided to do. So I'm pulling this from this Physiopedia website, which pulls a lot of the stuff off of the APTA website. Risk factors, obviously, it's older people, heavy overhead activities. I'm just not like I was in my 20s and 30s. So yeah, I do overhead pressing, but I'm not doing 1, 2, and 3 rep maximums. I'm also not taking myself to muscle failure. So maybe that applies to me, but I don't. While I do press overhead when I'm doing resistance training for my shoulder, I don't emphasize it. So I'm not sure if that was really a factor. Shoulder overuse, including tendonitis. I absolutely had biceps tendonitis pretty bad several years ago, so maybe that played a role. I do not have shoulder impingement, so that couldn't have played a role. Never injured my rotator cuff, at least not symptomatic that I know of. Don't smoke, don't use corticosteroids, and yes, I'm a male, so that puts me at higher risk. Clinical presentation, it wasn't really an audible pop. I felt it pop, but it wasn't audible. I did not have shoulder pain, and there was no snapping sensation. Once my biceps actually ruptured, I was smart about not doing overhead activities, but I wasn't having any pain if I put my arm overhead. I had maybe some anterior shoulder discomfort. It wasn't really at night. I wouldn't call it pain. It was more on the discomfort pain continuum. It was just discomfort. It was very localized, right there in my anterior shoulder. And once again, I've never had a rotator cuff tear, at least not symptomatic, nothing that I know of. Yes, I had biceps tendonitis, and yes, it was actually pretty bad several years ago. No shoulder impingement, and then it definitely presented itself as a Popeye deformity once the rupture occurred. So I'll be able to fly through these next slides because I decided, since this is what I do for a living, I decided that I was going to bypass not only surgery, but traditional physical therapy, which you'll understand why in later slides. So this is coming from, I think it's called choosept.com, which is associated with or affiliated with the American Physical Therapy Association. But although having said that, I pulled this off of the physio, I forget the name of it, but it's in an earlier slide, off of their website, Physiopedia.com. And so the APTA's suggestion for conservative management, which I did not do, is that week 1, they call it the acute phase. And as you can see, it's mostly range of motion related, and not strengthening, with the exception of early scapular strengthening and stabilization. And I could bypass this because I wasn't in pain and I had full range of motion. Phase 2 is just a week long. It's week 2. They call this the subacute phase and early strengthening. And as you can see, it's mostly just TheraBands for the and doing external rotation with the TheraBands at a 30 degrees of abduction, and then the seated row machine or low rows, and then something called a ceiling punch, which I'm not really familiar with, but I can visualize what it might be. But I bypassed this one. Phase 3 is also just a week long. They call it advanced strengthening, where they're doing proprioceptive neuromuscular facilitation patterns, so cross body stuff. Bear hug, which is just a chest fly, but you're exaggerating a little bit, so you're getting a little bit of shoulder protraction for the serratus anterior. Reverse flies for your mid and lower trapezius, and internal and external rotation at 90 degrees of abduction. The reason why I bolded push-up progression is because I could tell when I first started my rehab, which wasn't till May 9th. So the injury occurred on 3rd and 8th of April. The MRI was the 12th of April. I spent the next couple of weeks just tapping into my network to speak with orthopedic surgeons, physiatrists, and some physical therapists. And in the meantime, I just wanted to let it go, even though I probably shouldn't have. And I really didn't start my rehab until May the 9th. But I could tell when I started my rehab that push-ups was something that would have been contraindicated for me. I just really lacked stability with my rotator cuff, and being in that position or a plank position. I could just tell that my shoulder did not want to be in that position. And there's no way I would have been able to begin with any type of plyometric exercise, anything explosive. I wanted, just intuitively knew to stay with controlled movements. And then week 4 from their suggestion is return to activities, continue with your program, reevaluate with a physician and therapist, advance the sport, et cetera, et cetera. And there's your source, choosept.com. So that's what they're suggesting. Here comes a video, I think it's about 5 minutes in length, that is going to show you what I've been doing. This video is a quick update on my shoulder rehab from a ruptured biceps tendon and a large tear of my supraspinatus tendon. Currently 9 weeks out from this 2-phase injury, where the biceps rupture and the rotator cuff tear happened on April the 8th, and I'm way ahead of where I thought I'd be when the injury first happened. I started my rehab on May 5th, about a month after the injury, and was only chest pressing 30-pound dumbbells for 2 sets, rowing about 60 pounds for 2 sets, and trying to figure out what shoulder exercises I could safely perform. The back row exercises felt fine, and although I did feel some discomfort when performing chest presses and shoulder exercises, it was minimal. But I purposely went very light on everything, because even though it felt fine while I was doing it, I was a little apprehensive about how I'd feel over the next couple of days. On May 23rd, my chest press was up to 40 pounds. Back rows were up to 110 pounds. And I increased my volume to 3 sets of each instead of just 2. I felt like I had found safe and productive upper back and shoulder exercises with face pulls, cable lateral raise, which includes some shoulder external rotation, cable 90-90 for my rotator cuff. There you can see my Popeye. Some biceps curls and triceps pushdowns exercises. At this point, I was noticing it really felt like my shoulder was starting to heal, because I'd feel less and less discomfort during the workout, and during activities of daily living, I'd also feel less discomfort. By May 31st, I was chest pressing 50-pound dumbbells, rowing 130 pounds, both for 10 reps. And I also increased my volume to 4 sets of each. Stuck with my same shoulder exercises because if it ain't broke, don't fix it. These exercises are working, and I prefer not to change anything right now. Last weekend, I traveled to Knoxville to present at a physiatry conference, and I wasn't able to get in and work out because of it. So you can tell this is from 2 weeks ago. But yesterday, during my leg workout, I decided to try deadlifting for the first time. After a quick 2-rep warm up with 135 pounds on the bar, I got 8 reps. It felt like a moderate warm up, and my shoulder felt perfectly normal and stable. Can you hear me? I can tell that I went out again.
No, you're good.
All right. So just real quick, this video I created about 2 weeks ago or so, and I kind of added just a couple things at the end, which is coming up here in a second. But I also wanted to state that I was really apprehensive about doing deadlifts since my arm is in a similar position as when the injury happened. So interestingly, even though with chest press, it's actually putting the chest press is what puts my shoulder in the most vulnerable position of any exercise I'm doing because of the loads and just the position it's in. And yet deadlifts is what I was most mentally apprehensive about because I know I can lift some, okay weight, and I'm not going to win any powerlifting competitions, but it's not lightweight. And that was similar position to, my arm is in a similar position during deadlifts as it was when the injury occurred. But when I performed deadlifts, pretty quickly, that apprehension disappeared because I could just tell that everything felt like as normal as it could possibly be. Today, I continued to progress, chest pressing 55 and then 65-pound dumbbells for 10 reps. So once again, this is 2 weeks ago. Didn't have 60-pound dumbbells, which is why I made the big jump. But everything continues to feel pain-free and stable. Actually, maybe even 3 weeks ago. I can't remember. The slight discomfort I had in the front of my shoulder during the first few weeks during chest presses is now completely gone. Threw in barbell rows for variety, 145 pounds for 10 reps. You see the Popeye again. I continue to stick with a volume of 4 sets for my chest and back exercises. I also continue to stick with my standard shoulder exercises. I doubt I'll add in anything different for at least another month or so. My bicep curls are up to 30 pounds for 10 reps, and I don't feel any of the fatigue or cramping that I've been told would happen. I've been doing a second workout each week during the week. I stick with 2 to 3 sets of everything and about 75% of the weight that you see in these videos. So I purposely haven't been recording them. Yeah, so please keep that in mind. I'm not only doing 1 workout a week. I do 2 workouts, my heavier ones on the weekend, and my light are like really light. They're like baby warm-ups just to stimulate the muscle groups, but they are not working sets at all. They're really light on purpose. Oh, hold on a second. This video is a quick month or so. Percent of the weight that you see. So overall, I've been progressing at a much faster rate than I thought would be possible when this injury first happened. I don't feel like I've lost much strength at all. I think I'll be back up to at or near pre-injury strength levels by the end of the summer. So now there's no audio here, so I'll talk. This is from 2 days ago. I'm up to 315 for 7 reps on deadlift. Still feel completely normal, stable, 0 pain. Feels like no injury ever happened when I'm doing deadlifts. And then with chest press, last week I progressed to 70 and then 75-pound dumbbells. And then yesterday I started with 75 on my first set, felt like a heavy warm-up, light working set range. So I went to 80 on my second one, which felt like a working set. And this is the first time I've loaded up with a weight that was really a true working set. I actually terminated at 7 reps when the plan was 8, because I just didn't want to go to muscle failure or too close, but I continue to feel normal. And by the way, so here's a single arm cable row with a whole stack, 150 pounds for 8 reps. So in any case, before I get to the reason why I have this slide up, and of course I'm biased towards myself and, and my skill set and all that stuff. But, the way I look at this is I'm, way ahead of where I would be if I had gone through traditional physical therapy, probably light years ahead, unless I was with someone who really understood how to progress somebody like me. Um, and so I'm really glad that I chose that route. And I also, the reason why I put this slide up is because if you compare what I'm doing to the general stages of rehab, there was no pain, swelling, or inflammation. So I was able to immediately bypass that. There was no restrictions in joint range of motion. As soon as the rupture happened, 24 hours later, I'm back to my normal pre-injury range of motion. So I could bypass that. Stage 3 in physical therapy is where you're working on motor control or proper form, which didn't apply to me, and where you're including a lot of what they suggested on my previous slides from the APTA, where it's I's, Y's, T's, W's with a TheraBand, which I'm including cable versions of some of those things, but I knew that I could immediately jump to stage 4 as long as I was smart about it, and then just include therapeutic exercise as needed. So I kind of want to just prove to the world that a 55/56-year-old person could rehab themselves back with primarily traditional physical therapy. So I've had I lost it again. You
Yeah,
can hear
you're
me?
good. You're back
All
now.
right. So I've had people tell me that the reason why I've been able to progress so quickly is because of my baseline of strength. And while that may have played a role, I don't completely agree. I'm doing for myself so I work in post rehab. 99% of my patients are referred through physiatry or physical therapy. Since, as you may hopefully are aware, in physical therapy, unless it's like ACL or post surgery or something like that, where the rehab's going to last for months, generally speaking, rehab only lasts for 6, 8, 10, 12 sessions. So it's really only a blip in time. And by the time they're referred to me, I'm really truly an extension of what physical therapy is. And what I'm doing for myself, while I'm able to progress a lot faster because I know myself, because I wasn't experiencing pain, from a concept standpoint, I'm not doing anything different. I'm hardly doing anything different for myself than I would for anyone else. And what I mean by that more specifically is I followed for myself the ACSM guideline to start low, which means that you start with a familiarization or adaptation phase. And that's exactly what I did in week 1. I was apprehensive. I didn't know. The first dumbbells I picked up to chest press were 17 and a half dumbbells, 17 and a half pound dumbbell. So once again, my capacity for 8 reps or 10 reps was probably about 85 pounds. Pre-injury, I picked up 17 I was capable of pre-injury, and immediately knew that this was nothing. And so I quickly went to 22 and a halves and 25s, and then I ended up using 30 pounds for my working sets in the first rehab session, which is still only about a third of what I was capable of. So I really went down in my capacity from a well, I'll get to the RPE here in a second, but the point is that I did my own physical therapy. I determined my available pain-free range of motion, just like I would with anyone else. I determined the appropriate, I used about 2 sessions to determine my appropriate exercise selection, which is what I would do for anyone else. I started with really conservative weights, which I would do with anyone else. And then I used my own feedback to myself, um, on to help guide my rate of progression. And then so now that I'm back up to my true working set range with back, with chest, and actually even with these shoulder exercises, now I'm going to, starting next week, starting this upcoming weekend, I'm going to start periodizing. And what that's going to mean for me is I'm actually probably going to go down to, I'm going to have one more week at 8 repetitions per set, which will be 3 consecutive weeks. Then I'll actually probably go down to 6 repetitions per set, but just for like a week, just so I can lift that heavier weight. But then I'm actually going to do a um, a non-linear, and I haven't decided exactly what I'm going to do yet, but for example, I'll probably go up to 12 to 15 reps with much lighter weight, stay there for like a 2-week phase. Then I'll drop down to 8 to 10, stay there for 12 for a 2-week phase, and then down to 6 to 8 for a 2-week phase. And by the time all that's finished, we'll be in September range, maybe closing in on October. And I'm hoping that with time healing the wound, going along with all that strengthening and everything, that I'm really hoping that I'm back to normal, back to pre-injury strength levels, but we will see. So that's the game plan. But the truth is, I do that for everybody. The only difference is I'm going to put myself quickly on a non-periodized, a non-linear periodized program like I just described. Whereas with anyone else, I wouldn't do that. I would start with them with a linear protocol where I'd move them to 12 to 15 and I'd stay there for 3 to 4 weeks. And then I would drop them to 10 to 12 for 3 to 4 weeks, 8 to 10, and then maybe 6 to 8. That would depend on the person, the situation, etc. And I also just wanted to show from an RPE standpoint. Once again, in week 1, I purposely was choosing loads on everything that it only felt like a 2 or a 3 with all my exercises. And I just made sure that my body was responding, my shoulder was responding appropriately, no pain, no discomfort, no throbbing, nothing at all, which was the case. And that's the reason why in the next session, all right, I can tell I just went out, but I can tell I'm back. So
Yeah, you're good.
Yeah, so in the next session, that's the reason why I then went up in weight, and I chose loads that would take me to like a 4 or a 5 RPE, which is still in the warm up for a week or two. And then as you could see in the video that I had, I just kept going up and up until I finally got myself into a true working set loads, which really wasn't until last week. So the point is that for the first 6 weeks, I was progressing, but I was progressing in warm-up set range. And then it's only been for the last 2 weeks that I've truly been in working set. And that's the reason why once you're starting to do true working sets, it's time to, take the training wheels off and start figuring out what type of periodization you want to do, whether it's a linear model, which is what I do with pretty much all my clients, or for myself, a nonlinear. So what applies across the board, and this is really probably one of the most important parts of the presentation, is it's just a matter of determining the person's initial capacity. I use this RPE method as the way to do that, but I'm also going to include the severity of pain. So the more the pain is, that's obviously going to then affect my exercise selection for that individual. But the more severe the pain, I'm going to stay lower on the RPE, or in other words, choose lighter weights and not even come close to taking them to a true working set or muscle failure. And I'm also going to take their fitness level into consideration as far as what RPE I'm going to RPE. Hopefully you were at my previous presentations, but when I talk about RPE, I'm also simultaneously talking about the loads that I'm choosing. So if it's a low RPE, like a 3 or a 4, then it also means that it's really light weights and light warm-up sets. So these are the main things I'll do for not only myself in this case, but also just everybody, is determine their initial capacity, and so I can work within it, rather than just for everyone choosing a yellow TheraBand and just kind of standard exercises, standard kind of like physical therapy exercises. Instead, I go this route. And then, like I said, I'll use low RPE, and I'm getting tons of feedback. How's your body feel? How did your body respond to the last session? How did that set feel based on the feedback? And then once again, once we get up into, well, I progress them in small increments, just like I did myself. It's driven by the RPE method. As long as I'm feeling okay, I'm going to slowly start to move up on that RPE scale, continue to get lots of feedback. I also am of vary intensities, which, like I said, that's what I do for myself. I don't have the same intensity every session. So for me, it's once a week. I'm having harder sessions. But even when I was earlier on in week 2, week 3, week 4, And even though the RPE was low and the weights were light, I was still going lighter during my midweek session. So I always vary intensities. I also want to point out that you don't have, once you get to where you're training where it's harder weights, like I'm doing now, and it's in a working set range, you don't have to go the same intensity every single set. Like, for instance, that last set was an 8. That last set of chest press was an 8, 8.5 on a scale of 1 to 10. But the one that preceded it was only about a 7. And the one that preceded that was only about a 6.5. So as long as one or two of the working sets are legit loads, you will progress. But it's really important to vary intensities. And now that I'm kind of, my training wheels are off and I'm up in the true working set range, I'm going to make sure I start increasing variety. I just didn't want to do that early on because I wanted to stick with what was working for me, but I'll start to increase variety. And I'll also make sure for myself, but especially with patients, that whenever I move from one phase to the next, I don't, like, for instance, if I was training all of you and we just finished a 4-week phase at 12 to 15, once we drop to 10 to 12, I'm not going to immediately like significantly increase the load. I'm going to use the first week of that phase as kind of its own little familiarization phase, and I'm going to ease you in to heavier loads. So yes, I'll increase the loads because we're doing 2 less repetitions per set, but I'm going to ease you into it. And the difference between the loads we're going to use in the new repetition range versus what we just got finished the week before is going to be almost insignificant, because I just want you to experience success and not feel like you're really feeling significant increase in load. Because if we're going to be there for 3 or 4 weeks and I can work on increase your loads in week 2, 3, the mind frame is the reason why I do that. So obviously, unfortunately, case study, even though it isn't that long. And I can tell I just went out again, but that is really just going to unfortunately be the presentation for today. And let me just apologize profusely for what is going on with my internet. I'm telling you, like, this literally never happened. So I can't believe it's happening today. But I'm curious if there are any questions or comments on what I was able to present on.
There's a first time for everything, so don't worry about that. I'm curious, what is the what is next for you? I guess, what is what you're looking for? What is your ultimate outcome? Obviously, surgery is not going to be it. So, are you looking to what percentage would you say would you be happy with getting back to from your previous self to consider this a success?
Given that I'm already back to 80 to 85%, and I have read and have been told by a couple of the orthopedic surgeons I spoke to, and one of the physiatrists, and actually a physical therapist, that I could expect to be back to possibly 100 and definitely in the 90 to 95% range. I'm already at 80 to 85%, and I only have 7 weeks of true rehab under my belt. So my expectation is that I'm back to normal, or like really close to normal. Now, having said that, my days of doing first of all, I hardly ever do 1, 2, 3 rep maxes anymore because of my age, and I'm just done with those days. But I'm definitely done with them now. With my upper body. Probably 6 reps per set, maybe 5 is as low as I go, and I won't spend very long phases there. I'll just do it just to try to keep my strength up. Since I'm no longer, I was an athlete back in the day, but my days of playing sports are over with, so I don't have to worry about overhead throwing, and it's my left arm anyway, and I'm righty when it comes to throwing, but I don't have to worry about explosive stuff. So from a lifestyle standpoint, I just want to get back to what I was doing in the gym pre-injury, and I have full expectation that I'm going to be there hopefully within the next couple of months. Let me also say that I do still have an apprehension, since I have a large supraspinatus tear that includes retraction, that one of the orthopedic surgeons was concerned about, which is why he recommended surgery. So he planted some negative seeds in my head. I do have an apprehension about ever doing overhead presses again. So I may or may not, I'm not really sure, The next option would be a landmine press where you're pressing towards overhead, but not completely overhead. Maybe I will, and maybe I won't do that. I'm not really sure. But right now I'm just kind of keeping in the safe zone. So it's just a lot of, as you saw, face pulls, reverse flies, um, cable lateral raises where I just never go above 90 degrees in shoulder, abduction or anything like that. So kind of just staying in the safe zone. So I do have an apprehension about going overhead, and will that affect the rest of my life? If it does, it's not the end of the world. But I'm a little concerned about progressing that tear and ending up with some sort of rupture. What else?
Thank you. Anybody else have any questions? Feel free. You guys should be able to unmute yourselves. Let me make sure. Yep.
And I'll just
All right. Well,
let
with
me
that,
let me just
yeah, go ahead.
Andrew, let me just say one last thing. Since no one has any questions, I just want to say one last thing in closing. And it's I'm repeating myself, but I just think it's really important that when it comes to post rehab, this rehab and post rehab obviously really overlap. And yes, if I had bruising, swelling, inflammation, pain, then it would have been a different story. And obviously you have to tackle that first. And I would have gone to traditional PT. So I don't want to make it sound like I'm anti-PT, because I'm definitely not. I just want to reiterate that the reason why I bypassed PT is because those first two stages of PT didn't apply to me. I didn't have pain, swelling, inflammation, and I had my range of motion. So I was able to jump right into, basically the therapeutic strengthening, because I know what I'm doing from a periodization that. And so that's really my view. And when I have patients referred to me, by the time they get to me, they've obviously either bypassed PT because they didn't have pain, swelling, inflammation, and the range of motion was either normal or near normal, or they had gone through traditional PT and that stuff was taken care of. So by the time somebody gets to me, I already am in that stage 3, and want to start stage 4 with them as fast as I can, with motor control, the familiarization phase, et cetera, et cetera. So I just want to reiterate how important it is to understand that a good practitioner or coach, whether physical therapist or somebody like me, is going to understand how to use those RPE scales, and some experience with how conditioned or deconditioned the person is, to find their initial capacity. You can't just default to just ultra conservative stuff, yellow TheraBands for everyone. You use the first couple sessions to find the person's initial capacity, and then you use those RPE scales and feedback to progress them. And their feedback is really going to determine the rate of progression. But if they're from session to session, obviously time's healing the wound. And if they're basically voicing to you that, yeah, I didn't have any soreness, I had no pain, I feel fine, etc., then we want to strengthen that tissue as a primary goal. And so that's been my primary goal, and for myself. And I'm just fortunate that this is what I do for a living, and I know how to do it. So hopefully I won't screw up and injure something, but things are really going well. Much better than I anticipated to this point.
Well, thank you very much. This is very insightful, especially for those of us who are aspiring to do physiatry anyways, is to see that rehab might be better than surgery sometimes, depending on your patient. So we just need to listen to our patients and go based on what they want to do. But thank you very much. Hopefully next time we will have less technical difficulties, but 'tis the world we live in now. So it happens. So we look forward to your next talk, and we'll hopefully get that MS case study done then. So thank you all for coming out tonight. I appreciate it. And we will see you again soon.
All right. Thanks so much, Andrew. And I'll talk to you soon.
Sounds good. Take care, everybody.
Take care.